Hello, thank you for having
Hi,
me.
welcome. Thank you very much for coming. That's a really clear, excellent presentation. I was going to ask you about recall bias, but you kind of beat me to it in the presentation. Um, do you think that that was very significant within your population? And have you thought about setting up a prospective study to look at this as well?
So we are doing a variety of things prospectively, and that's part of one. But I think there's certainly some recall bias. But it was interesting that the patients who had had CCH most recently were not more likely to say CCH was better, whereas the surgery patients who had had surgery most recently were. So I think there's something there.
Yeah, and I guess the other thing is that how close to the start of the learning curve do you think you were for the CCH as well? Because it was relatively early after it was introduced, wasn't it?
Right. So, and then the other thing about these patients is that not only was it early on, it was FDA approved in the U.S. in 2010. So these were the first few years of everyone. So I think we were all getting better and more comfortable with it. But this was also contacting patients at least 5+ years out from at least that treatment, and some of them had had other treatments in the intervening years for their Dupuytren disease. So I think that may have had some impact on it, although I don't know that our outcomes have been significantly different over the time.
Right. Okay. There's a question from Wolfgang Wack, which is 12% of patients getting skin tears typical for CCH? Again, this may relate a bit to the learning curve, I guess.
So I think it's variable depending on what time frame we happen to pick, but this was a little bit lower than I think sometimes we've gotten up into the or 18% range. So not an insignificant number of skin tears. So I don't see skin tear as a necessarily bad thing. I haven't had to take any back to do anything other than local wound care, which they do at home under my tutelage, as well as the hand therapist if needed, and even large tears here heal quite nicely. So so while it's technically a complication, I actually think it's okay. I tell everyone they may have it.
Yeah. And I suppose if you're making a cut in the skin, you're definitely going to have a skin tear, right? So,
Indeed. Indeed.
Jeremy, do you have any questions?
I find this really fascinating work. Do you think that there's influence by clinician and what the clinician is saying? One of the quotes you had was, "My CCH made my subsequent surgery harder," and I can almost hear a surgeon chuntering along as they're finding a particularly difficult operation going. The things that we say and the impact that they have on people. Do you think there was bearing, and do you think there was variation between clinicians in your service?
I think I'm sure there is, and because we influence our patients tremendously. Interestingly, my smaller group of partners that was involved in this study, actually, we fairly uniformly don't believe that it makes surgery particularly harder, and we've published on that too. So I think it probably wouldn't have come from us, but some of these patients had either a CCH or surgery treatment with other providers. They may have moved, or they may have sought different care subsequent to this, or even prior. So it could come from anyone that they may have interacted with along the way. But I do think we influence people quite significantly. And one of the things that my partners and I have been particularly interested in is trying to look at studies that provide patients some answers that they might commonly have. And a lot of people say, well, gosh, if I had to do both, and I use this to talk to them about what other patients have found to be pros and cons, and it does not mean that we're operating on everyone. Many patients, even though we tell them, people who've had CCH and then had surgery, more of them are interested in, or would say they preferred surgery, and they still say, many of them, I get it, but I'm more interested in the quicker recovery, and I don't want to have a scar. So I'm willing to do that first, even if I have to come back in a few years with a recurrence, and then we can reconsider whether I need treatment and what treatment I do at that time.
Yeah, I think that certainly chimes with my experience. We don't have collagenase in the UK, but I do a reasonable amount of needle fasciotomy, and many of my patients say that I'd rather have a go at this, and if it does work, then that's great, and if it doesn't, well, at least we can have surgery in the end.
Right.
Anna, do you have any questions at all from the sort of patient perspective?
I was wondering, do patients not complain about any of the side effects such as swelling, pain?
I think they notice it, but I kind of tell them ahead of time that your hand is going to look like you had surgery without a scar. And because they come back for their manipulation and they are ecchymotic or really bruised, they're swollen. Many of them have soreness and lymphadenopathy in their axilla on that side. And so as long as they have kind of appropriate expectations, they're not really surprised by it. They're kind of expecting that. But I do think it's significantly quicker recovery for these patients.
Okay, we've got one last question from Charlie Eaton. Was there any correlation with either initial angular correction or what the angular correction was at the end of the last procedure with their sort of choices?
So it's a fantastic question, and the answer is I wish I had that information, but we don't. And so I think that'll have to be future work to correlate, what patients' actual outcome is, and their condition going in, their outcome from it, and how that affects their preference, because I'm sure it does, but that wasn't what we were able to do with this study.
Yeah. Okay. I think that is a great topic for future work. I think we've come to the end of our questions. So thank you ever so much for joining us from over in the States. Brandon, that's fantastic. And thank you for an excellent paper as well. We've certainly enjoyed that. I'm going to send you back to be an attendee. I do apologize. Bye for now. Okay. So the final thing for this evening is just to announce the winner of the Best Presentation Prize from our free papers. Following Jeremy's idea that you should never go to sea with two clocks, we did have two judges, but we decided to get a third judge, and I'm really pleased that we did, because the first two judges voted for different people. So I wouldn't have known what to do, but the third judge has come through and decided that the prize will go to Bente van der Berger from Groningen for her presentation on PROMs predicting the need for surgery. So congratulations, Bente. We will be in touch, and we thank you very much for your presentation. I'd like to thank all the free paper presenters this evening. I think they've been a very high standard. And of course, I'd like to thank Jeremy again for his excellent keynote speech, which really set the tone for the evening. And finally, Anna, thank you so much for joining us as a panelist. It's great to have the patient voice, and I think we've had the patient voice coming through a lot in our questions as well, and that's really part of what these symposiums are all about. We have one more symposium to go in the series. It's in 2 weeks' time on the 1st of December, and it's all about exploring new treatments for Dupuytren's disease. We have Jagdeep Nanshahal from Oxford University as the keynote speaker, who's going to be talking about a trial that he's been running using anti-TNF treatment in Dupuytren. So we're all very excited to hear hopefully hear some results from that. I think the analysis is happening as we speak, so it'll be really hot off the press. So do go along and register and join us for what I hope will be a fantastic evening in 2 weeks' time. Thank you very much, everyone, and good night.